Thank you, Lita, giving me this honor. And thank you, Girija. That is quite a flowery intro. Uh, Update on angle closure, there's a lot of aspects we can go through, but I will primarily sit at a few studies that have come out recently in terms of the management. Angle closure, unlike open angle, is primarily a surgical disease. We know that we've always considered relative pupillary block as the cause for closure. Iridectomy needs to be done, laser is easier, so an iridotomy is what is the standard of care. So now, off late, we have questions being raised. Do we need it? Does it work? And especially at a situation like PACS, which is like OHT in OAG, where the patient doesn't have a problem, but we are saying you're going to get a problem sometime in life. And the data we always had, which we never gave much credence to, it has always been published, is that Vellore Eye Survey had 22% of PACS progress to PAC in 5 years, and none of them actually hit PACG, that means disc and field changes. So PAC to PACG, PAC, all of them were advised PI at Vellore, and 11% of the people who underwent PI still progressed to PACG. They progressed in the disease, as opposed to 36% who refused PI as a procedure when they initially screened. And Chennai Glaucoma Survey also underlined the fact that, from all those people that progression over time with age is actually quite low as far as closure is concerned. And 5-year progression from normal to PACS was PACS and PACG spectrum was 4%, and most of these only achieved PACS, which is actually questionable. Occludable angle is what you're talking about here. So we know that incidence of PACG is low. I'm not talking prevalence, it's incidence. And PI does protect, but does not protect everybody. And out in the recent past, we have got the ZAP and analyst trials. ZAP stands for Zhongzhang, how is pronounced it, Angle Closure Prevention Trial. They screened about 11,000 people for eligibility and found 870 people who had 2-quadrant apposition, which is what they wanted. And PI in one eye and the other eye was maintained as a control. 6-year follow-up. All these were from, Chinese province, so China. Indentation gonioscopy was not used to diagnose PACS. 2-quadrant trap not visible with no PAS or disc changes and IOP less than 21. And those who they did a provocative testing in terms of prone provocative, and those who went on further were given standard of care, and 30 mm Hg or more was needing standard of care, which is PI. Of these, only 454 were analyzed with anterior segment OCT, and they found that PI made no difference. That is, 1/4 of the angles did not open up with the PI. For some reason, they found that the superior PIs, the reason for doing a superior PI and the other PI somewhere else is not mentioned, had a greater opening up, and they concluded superior location is better. And I would say one more reason to prefer superior location. That's about it. And final results, PAC, primary angle closure, Synechiae onwards, occurred in 4.19, and as opposed to 7.97, they reported in 1,000 eye years, and the outcome occurred in 19 patients in the 400 and something odd on each limb, and as opposed to 36 patients who did not have the PI. I'm sorry, it's one eye, so it's 800 odd patients. 19 had closure coming post PI, and 36 had closure coming without PI. Mostly this closure progression was PAS. So in other words, the risk was approximately reduced by half, 4 by 1,000 year with PI and 8 by 1,000 year without PI. ZAP info again is PSC to PSCS incidence is low. PI does not protect all. PI reduces the risk by a factor of 2. Analysis was done by quite a lot of people who are involved in the ZAP, so a lot of problems are ironed out. This is a better study as a consequence. And similar protocol, 480 individuals in Singapore, over 50 years, 2/4 position, PI in one eye, other eye is controlled. Outcome was Sinike or PSCG or acute closure. This is not there in the other one. They had closures and they had to take patients out. But once again, most of the patients are Chinese and a predominance of women in the group that they had for analysis. And here, in 5 years, again, this similar results. That is 5% as opposed to 9.4% with PI and without PI. So essentially the hazard ratio is half, which means PI protects to a factor of 2, but not everybody is protected. They found out that the hazard ratio is around 1 for older participants and higher baseline IOP. This is something that we need to keep in mind. These are the patients where PI did not protect at all. Hazard ratio 1 means no protection, but the number suggests that it was worse because just over 1, but once you calculate the confidence interval, it is crossing 1. So it's okay. So higher IOP to start with, and older patients, PI is less likely to work is one thing that they came out with. And you need to treat about 22 people with PACS for one patient to benefit theoretically from the incidence they got. So risk of progression reduced by half. Absolute risk of progression without PI is not very high. So older patients and those with higher IOP at baseline, the PI is less effective. So we are justified now to do a PI or observe a PACS patient, but either way, we cannot avoid serial gonioscopy and IOP measurement and follow-up for any of these patients. So that brings us to the next aspect, lens vault. That's something we're talking about off late. And way back in 2012, Singapore, they showed that they compared lens vault of PAC or PACS versus control. 775 microns versus 386, about double there again. Lens vault, by the way, is an ASOCT parameter. From scleral spur to scleral spur, you have a line and how much of it sticks up above it. And a Korean study about PSCG, they found a huge difference in the lens vault between PSCG versus what is deemed as normal controls. So we have proof now to suggest that lens contributes to a shallow AC and consequently to angle closure disease. That brings us to EAGLE, a study which I have a lot of reservations about. I'm sure a lot of people have reservations. It was a multicentric study, age 50 plus, new diagnosed a PSC with 30 mm Hg or more, or PSCG with 21 mm Hg or more with disc and field changes. No cataract, that means the clear lens they were looking at, no previous history of closure. And this is one statement that's there at the start of their study, that is, they started the report saying that the study had the power to find a difference of 1.75 mm Hg. Keep that in mind because I'll come to that again later. One of the main instruments used was quality of life questionnaire, and clearly in the methodology, this statement is there. If there's a missing answer, we followed the author's recommendation. That is, that center's coordinator for the study had to give an answer for the question if the patient did not answer the question. That doesn't make sense to me at all. And the complication rates also raise a flag for me. 25 complications in lens extraction and 50 in PI group, and more complications were hence there in the PI group. But if you look at the list, PI, most of the complications were bleeding. That means hyphema, which is a very common innocuous complication of a PI, is what it is. And they also had 2 malignant glaucomas post-PI. This sounds surprising to me. A retinal detachment post-PI, that is surprising to me. Flat anterior chamber post-PI, that's surprising to me. So I have to take this complication list. If you go down the line, there are more of these, but I just marked 3 or 4 that are put together on the table. There's a lot of salt to be taken, not just a pinch. And they finally said they have a difference of 1.18. They said they have power to pick up something about 1.75. They got a difference of 1.18, and they favored lens extraction based on the quality of life questionnaire. And quality of life questionnaire, once again, they had a difference of 0.52, which is essentially one question. And believe me, most of these patients are hypermetropic to start with, and once you do a lens extraction and put an IOL, what do? We don't aim for hypermetropia. That just may explain this one question still. And this is the biggest of the lot. Not every patient had a gonoscopy. So I don't know how they came to the inclusion in the first place. Anyway, I think I'm running out of time. So. Anyway, if you take this graph, this may take some time. There is quality of life scores on one side and IOP on the other side, and the nearer the blue line favors standard of care, the PI, and nearer on the other side of the red favors the other one. If you look at it, beyond the red is primarily only the Chinese. Rest of them, most of them are landing up outside. So there again, the demographics also makes a difference. So what do you do in closure? PACS to PAC, low incidence. So PI or watch, both have a rationale. PI does not prevent closure and all. So doing a PI does not absolve us of the need for follow-up. It is absolutely essential. Role of clear lens extraction is unclear. Lens vault indications are not yet defined. So please do not go for a clear lens extraction. Definitely not without documenting a huge lens vault on OCT, not on a clinical basis. And if you find the slightest amount of cataract, you are justified. Early cataract surgery is okay. But having said that, these cataracts are special when you barely have space for the phacoprobe to get inside between the endothelium and the capsule. It's not for a beginner. It's for an experienced surgeon, these cataracts. Thank you.
That was an excellent presentation, Thomas. Actually, you put us in, I think, more of a corner, actually. All these doubts we also had, but the studies are stating like this, and early clear lens extraction, I think nobody follows that. But early cataract extraction is something that I think we can do in all these cases, post-PI cases.
I do favor it. Yes. I do favor early cataract extraction.
Early phaco will be more, because as the lens size increases, the space decreases and the complications are more. And always use some sort of protection for the endothelium. And a cohesive viscoelastic agent you can use. And the PI, the SAP study and all those are actually, I don't want to comment on all these.
About that complications post-PI which you had showed, I mean, I have seen post-PI done elsewhere, retinal hole, exactly corresponding to the point of the PI. So it is the YAG has gone through the PI and made a hole in the retina. And this patient had retinal holes in both eyes, exactly corresponding to the PIs, for which I had to take.
Which machine? Obviously the focus is not very good.
Well, it was done elsewhere, so I don't know.
You don't know the machine also,
yeah. So I mean, I had to do barrage around those holes. Fortunately, it didn't detach; just came with the hemorrhage. Dr. Gauri, would you like to come in?
I think Dr. George excellently, presented the controversial aspects of angle closure. Having said that, don't take the take-home message that PI is not necessary. I mean, this is only with respect to PACS converting to PAC. So when we are giving that message, we have to be very careful. Whenever you have a slight suspicion, elevated IOP, narrow angle, definitely PI is indicated. So Dr. George has told you that specifically in that context of PACS progressing to PAC. And another thing that I am at disagreement with what was stated there is superior position for the PI. See, earlier I started off, started off my career with doing all superior PIs, but then the incidence of patients complaining of dysphotopsias is very high, and when you are doing this for asymptomatic patients, some of them have very bothersome symptoms and they complain, I was fine and you did this and I have all these problems. So it's very difficult to justify. Doing an interpalpebral PI, that is near the 3 or 9 but not exactly at 3 or 9, the incidence of these visual complaints are much lesser. And as a bonus, there you see more crypts than you see in the superior this thing. So these, PIs, I think I routinely do them interpalpebral. Above, infratemporal, Dr. George says. For me, it is at the horizontal meridian, above or below, avoiding the vessels. So that, 3 and 9, either nasal or temporal, it's fine.
Thank you, Dr. Gauri. I also do most of my PS inferiorly.